Just give me 1 second. Okay, recording has started. So good morning, everyone. We are delighted to have Dr. Pierre Delanaye from Belgium, from the University of Liège, Belgium, presenting to us on estimating GFR facts and fiction. He's one of the foremost experts on measuring GFR across the world, if I might say so. He's an MD, PhD, and he's an active clinician with interest in looking after patients on dialysis, as well as CKD epidemiology, the frailty in CKD, and CKD-MBD. So without much ado, welcome, Pierre. Please go ahead.
Thank you very much. First of all, I would like to thank the organizer for this kind of invitation. So the title of my presentation is Estimating GFR Facts and Fiction. So I come from Belgium. So Belgium is a small country squeezed between France and Germany. And just to give you an idea of the size of Belgium, I put Belgium on the US map, and you see that this country is totally negligible, actually. But okay. Here are my disclosure. And let's go for the glomerular filtration rate. So GFR is usually the best parameter to assess the global kidney function. Of course, this is not the only one. We have other parameters, but clearly in daily practice, this is the most used parameter to assess the global kidney function. And you see here Homer Smith, who is the father of the renal physiology, I would say. So in daily practice, as you know, GFR is not measured, but estimated by a biomarker. And serum creatinine is one of the most prescribed analyses. After glucose, serum creatinine, once again, is the most prescribed analysis by the labs. But I think that as nephrologists, the most important is probably to know the limitations of serum creatinine. And I will discuss with you three types of limitation. The first type of limitation is, I would say, a sort of mathematical limitation. And the fact is that the association between serum creatinine and GFR is not linear, but hyperbolic. And this association explains all the limitation of estimating GFR and probably also the justification of using estimating GFR and not only serum creatinine. And you see two important limitations here. The fact is that in low GFR range, a relatively large change in serum creatinine will be associated with a small increase or decrease in measured GFR. At the opposite, in high GFR range, a small change in serum creatinine will be associated with a large change in measured GFR. First thing. The second point is this value, theoretical and arbitrary value, 0.9 milligram per deciliter for a man, for example, and you see the range of measured GFR corresponding to this value of 0.9, and you see the range, the confidence interval here, and it is different from men and women, and it is different from old and young people. So one serum creatinine value, a large possible MGFR results. And there are also a limitation. The second type of limitation is analytical limitation. You know that serum creatinine can be measured by different assays, two big families, I would say, GFR and enzymatic. And you know that sometimes we don't have exactly the same results with GFR and enzymatic method. But I must say that in the last decade, a lot of improvement have been made by the manufacturers, giving sailing serum creatinine, and the improvement is about the standardization, the calibration, the traceability of serum creatinine. And now you are relatively sure when you measure serum creatinine in one hospital, the result would have been the same in another hospital, because there are a standardization of enzymatic on creatinine assay, and this is especially true for enzymatic assay actually. Not so true for GFR, but okay. There are also what I call physiological limitation. Two types of physiological limitation, the tubular secretion. We know that serum creatinine is secreted by tubules, and so creatinine clearance is overestimating GFR. And the problem is that this secretion is totally unpredictable at the individual level. And even in the same patient, the tubular secretion probably will increase with the GFR with the GFR decrease. So it's very difficult to manage this tubular cell equation. So it's not a perfect biomarker for GFR. But also, of course, the second limitation is the fact that serum creatinine concentration is not only dependent on GFR, but also on muscular mass. We know that serum creatinine is a catabolite of creatine, and creatine is a protein of muscular origin. And so serum creatinine will depend on GFR, but also of muscular mass, and this probably explains difference that we can observe in serum creatinine between men and women according to age, and maybe, at least in part, according to race or populations. So many limitations for serum creatinine. So have we to forget serum creatinine to the trash? Of course not. First of all, and this is very important, this is a very cheap biomarker, especially the GFR SR, very, very cheap. Serum creatinine has a very good specificity. I mean, when serum creatinine is over the reference range in a patient, except if the patient is a bodybuilder, you can be relatively sure that the patient is a CKD patient. And also, the analytical performance by the labs of serum creatinine measurement is relatively good. And once again, we are relatively confident to have an IDMS traceability in serum creatinine measurement. A few words about creatinine clearance on 20 hours urine collection. You must know that this is not recommended, at least at first line, by any guidelines, and notably by the KDIGO. Why? Because creatinine clearance is overestimating creatinine GFR, because of the tubular cell equation. But the most important, and this is very, very important, it's the lack of precision. We have a lot of errors in the urine collection by the patient. It's very difficult to have a complete urine collection. And also, and this is frequently forgotten, we have to keep in mind that there are large intra-individual variability for creatinine excretion. So now we are moving to the estimating of GFR, and I would like to share with you only one slide about statistics. So we have to compare estimating GFR with measuring GFR. And so the reference is, of course, measure GFR, and we must have a good correlation between estimating GFR and measure GFR. This is a sine qua non condition, but totally insufficient. We have to to calculate the bias, which is the mean difference between the two values, and it represents the systematic error. We have to calculate the precision, which is the standard deviation around the bias, and this is the random error. Both precision and bias can be combined in a metric that we are the only one to use in the little world of estimating GFR, and this is the accuracy within 30%. And the accuracy within 30% is the percentage of estimating GFR results between plus or minus 30% of measured GFR. So a few figures to be more simple. You see this theoretical equation is perfect. All results are between plus and minus 30%. The bias is 0 and the precision is good. You see this theoretical equation, which is biased, because all results are given a result over 30% of the measured GFR. So the bias is present, but you see that the precision is quite good. The dispersion of the results are relatively limited, and all the results are close to the bias. And this is the opposite. This equation, this theoretical equation, is unbiased because the bias is close to 0. But you see that the bias is 0 because underestimating results are compensated by overestimating results. And so the precision actually is very low with a large dispersion of results. Two comments here. First, in some literature, sometimes the researchers are focusing on the bias, and the bias is very important. The systematic error is very important. But we must not forget the random error. This is still at least as important as the bias. Why? Because the bias, finally, is something that you can correct. If you know that the equation is overestimated by 30%, you have just to decrease the result by 30%. But correcting the precision is much more difficult. My second comment is about the accuracy within 30%, which is, once again, used in all the article, but we must keep in mind. That means that we consider as correct an equation with an accuracy at 13%. For example, I give just a simple example. If the measured GFR is 100 ml per minute, that means that an estimating GFR giving a result between 17 and 130 ml per minute will be considered as good. as accurate. But this is yet a large range of acceptance, I would say. So this is very important to keep that in mind. Once again, accuracy within 30% is not a very stringent criteria. So now, which equation? More than 50 equations have been developed in the literature. Of course, I have no time to go into the detail for each. You all know the Cockcroft equation, Canadian equation. But this equation, just in terms of estimating GFR, is probably the worst equation, at least in comparison with the new equation I am discussing after. I perfectly know that Cockcroft is still used in the context of drug dosage adaptation, but maybe we can discuss this point later in the discussion. But clearly, just for estimating GFR, Cockcroft is clearly not the best equation. So let's go for the CKD-EPI equation and the EKFC equation. You know, the CKD-EPI equation has been published by the team of Andrew Levy from Boston in Annals of Internal Medicine in 2009. And you see this equation seems a bit complex, an old equation, but of course now we have a computer that can calculate this equation for us. And you see that you see here, for example, that the exponent applied is different according to the serum creatinine levels. And you see also that there are differences between black and non-black and between male and females. This equation has been developed for a very large data set with measured GFR and creatinine calibrated. Not directly calibrated, but okay, we can consider they are calibrated. And what is actually the CKD-EPI equation? The CKD-EPI equation is simply, I would say, the result of regression analysis. On one side, you have creatinine, you have some variables like sex, age, maybe race on one side. On the other side, you have measured GFR, you do regression analysis between the two, and you try to develop an equation which fits the best with the measured GFR. And you see that the CKD-EPI equation, the bias in this data set was relatively good, with a bias close to 0, which was better than the previous equation developed by the Levy team, which was the MDRD study equation. And this equation was underestimating GFR in healthy people, leading to overestimation of the CKD prevalence. But you see also that the dispersion, so the precision of the result is not so impressive, I would say. You know that the KDIGO have been published in 2012, and the CKD-EPI equation has been the only one equation recommended by the KDIGO at this time. You also know that this KDIGO has been recently revised, and of course I will comment. I will have some comment on this revision later in my presentation. So what else than a CKD-EPI equation? I want to spend some time to propose, to explain this new equation that we have published in 2021 in Annals of Internal Medicine. And you see that this equation has been developed with measured GFR and with really true IDMS traceable creatinine. Most of the creatinine were enzymatic with enzymatic assay. You see that the sample size was also very large, and we also included in this analysis children and adolescents. In this seminal article, only Caucasian people were included and considered. And you see the new EKFC equation. And I want to insist on the fact that this new equation is not only based on regression, but really there is a physiological concept with the EKFC equation. And in the EKFC equation, the crucial variable is the Q value and the ratio between the serum creatinine of the patient and this Q value. And what is this Q value? This Q value is very simple, actually. This is the median serum creatinine value for a given population. And for adults, this is once again, very simple. The serum creatinine, the normal serum creatinine is 0.9 milligram per deciliter in males and 0.7 milligram per deciliter in females. In children and in adolescents, it's a bit more complex because you know that normal serum creatinine is increasing during growing, because probably of muscular mass gain. And so we have to include the variable age in the calculation of the Q value for children. And this is a bit different between males and females. But once again, this is relatively easy to establish and to calculate with computers. So the Q value is very important. And you see that there is a second number, which is 107, that we multiply to the serum creatinine, the ratio serum creatinine on this Q value. And what is this number of 107? And but 107 ml per minute is actually corresponding to the normal MGFR in an LC population. And in nephrology, we are very lucky because we have an LC population, which are actually the population of living kidney donors. And we have a lot of data with measured GFR. This is data from Belgium and France, close to 2,000 LC kidney donor with measured GFR. And you see that until 40 years old, the median measured GFR is 107. And this result seems quite universal. If we compare to data in Africa or even in US, we have more or less the same value of 107. But we also know that with aging, there is a physiological decreasing in MGFR. I think that Andrew Rula discussed this point with you in the last weeks. And so what is very important is to know that the association between MGFR and age is actually very different than the association between age and serum creatinine. Once again, you see here the association with creatinine and age, and contrary to measured GFR, you see that since from 25 years old, serum creatinine is constant and will remain constant in the population. This is how we establish the Q value. This is actually the Q value. There is a difference between men and females, and this Q value is very easy to obtain. And we simply take the serum creatinine of one patient in the database from large laboratories in Sweden and Belgium. We excluded patient followed by nephrologists, of course, and we keep all other results of serum creatinine to establish this Q value. So, because the association between age and serum creatinine is very different than the association between between MGFR and age, we think that we had to include the age in the main equation, actually. And so after 40 years, we include age correction, I will say. And of course, like for CKD-EPI equation, we know that the association between creatinine and GFR is also different in CKD and in LC people. And so we also use regression analysis for this part of the EKFC equation to define the exponent to be applied to serum creatinine, which will be different according to the serum creatinine level, and more exactly according to the ratio of serum creatinine on Q value. And here are the results in our data set. And you see in red the results, the bias of the EKFC equation, and the bias is close to 0 on the whole, quite a whole age range. And you see that the bias is especially better than the CKD-EPI equation here in black in young adults. It's also slightly better, but this is significant in the elderly population. And you see here in gray, this is the performance, the bias of the Schwartz equation, of the modified Schwartz, the CKD equation, also recommended by the KDIGO in children and adolescents. And you see that one problem to use two different equations is the fact that there is a jump, totally implausible jump, of course, nothing physiological in this jump at the age of 18 years old when you move from one equation to another equation. This is exactly the same picture for the accuracy within 30% with the best results, especially in young people and in the elderly for the EKFC equation compared to the CKD-EPI equation. So the added value of the EKFC equation is a better performance. Of course, it's not more expensive. It's just a calculation, I would say. I think that this equation is more physiological because all the corrections that have to be made regarding serum creatinine are done in the Q value. So at the creatinine level, not at the GFR level. And also we think that the age is better conceptualized in the EKFC equation than in the CKD-EPI equation. And finally, and I will comment that later, Q value can be specific to specific population. This equation is valid from 2 years to old age. We do not need for 8 for children. So this is one of the first equations in children without age, which is practically very important because that means that the labs can give automatically a result for children with the EKFC equation, which is not possible with the CKD equation because the labs are no access to 8 in most of the time. And finally, eventually also no implausible jump at the transition between adolescent and young adults. You all know the debate, the recent debate in USA about the race factor. First, a semantic remark. Of course, the word race should be used in its societal meaning, because we all know that race has absolutely no biological substance. We are all, there is only one human race. And I must say that in Europe, even using the word race in a scientific article could be considered as racist, actually. But okay, we will see that this is not only a question of semantic. We know, this is very clear in the literature, that serum creatinine is normal serum creatinine is different between black and non-black people, notably in USA. But this is also the case in Africa, when you compare African with Europeans, or between black Europeans and white Europeans. But the fact is that we are not sure to know why. We still don't know. We use serum creatinine for more than 1 century, and we still don't know with certitude why we have such difference between black and not black people. And this is really a pity. We know that MGFR is probably not so different between black and non-black. But you know that the race coefficient in the CKD-EPI 2009 equation was considered as a source of discrimination, and I can just tell you to read these two important articles in this field. So the team of Andrew Lever has proposed a new equation published in 2021, an evolution, I would say, of the CKD-EPI equation without including the race variable. And you see, this is the first time in the little story of estimating GFR that the new equation was actually performing worse, or at least not better than the previous equation. You see that in black participant and non-black participant, the 2009 equation was overestimating GFR in black participant, whereas the bias was close to 0 in non-black participant. And the performance actually in terms of p30, so accuracy, was slightly but significantly better for non-black participant compared to black participant. With the new equation, they show that once again, the new equation, the bias of the new equation in black participants is not better than the previous one, because now you are underestimating by the same intensity as you were overestimating before, but at least now the bias in black participant is comparable, the absolute bias is comparable in non-black participant, meaning also that in non-black participant, the new equation is performing worse than the previous equation. And also, now with the new equation, the race-free equation, the performance is balanced between black and non-black participants. And I have a lot of admiration for my US colleagues, but because they are very, very effective. This publication has been published online in the New England Journal of Medicine on September 23, and the same day, this equation was recommended by the NKF and the American Society of Nephrology. Very impressive. But the problem, I would say the problem for us in Europe and in Africa, but also in Brazil, is the fact that there are many, many publications showing that using the 2009 equation, CKD-EPI equation, with the race variable was actually inaccurate in black people living in Europe or in Brazil or in Africa. So it was a problem to use a new equation which is not performing better, for a problem that we don't have in Europe or in Africa, because we don't have to correct for race coefficient. And I will show you the result in this article that we published in 2023. So in this article, we had data from the EKFC consortium, of course, but we have enriched this data with data from Paris, which were very interesting, because we had a white and black European, a relatively large sample of black Europeans. And we had also the chance to have data from Africa with measured GFR and creatinine and cystatin C calibrated from Congo and Côte d'Ivoire. The sample size is relatively limited, but still it's of interest. And you see here the results. You see that in the white Europeans, okay, the EKFC, you already know this result. The EKFC has the best bias among all the equations. But you see that the new race-free equation here in blue actually the bias is still more important for the race-free equation than for the previous 2029 equation. In Black Europeans and Black Africans, the most important results is once again the yellow-orange line here, the bias, and you see that the bias is really very, very important, and this line is actually corresponding to the 2009 equation, CKD-EPI equation, with the Black coefficient. And once again, this is the worst equation. So we don't have to use the race coefficient in these Black non-US population. And you see that the bias is the best actually with the red line, and the red line is the EKFC equation with a specific Q value, specific to Black European and specific to Black Africans. These observations have led the European Federation of Clinical Chemistry and Laboratory Medicine to recommend not to use the race-free equation, but to prefer for the CKD-EPI equation version 2009 or the EKFC equation, and also the European Renal Association wrote this position paper to say that we probably should not use the race-free equation in Europe. So for our point of view with the EKFC concept, it was very interesting to see the performance of EKFC in US cohorts. And so we are lucky to have a large sample size of US cohorts with data from notably from Andrew Hall, once again with from the Mayo Clinic, and all other cohorts are interesting because these cohorts have been used by the CKD-EPI consortium to develop or to validate the CKD-EPI equations. And we also use Q value specific for US. So we use the Q value specific for US. So you use large database from laboratories published in this very important for us, for our concept. I mean, this important publication in Clinica Chimica ACTA from the University of Washington with a large amount of serum creatinine according to race. Okay. And when I say according to race, and I think when I said previously that it's not only a question of race, I think it's more a question of population. And this is the proof here, because you see that, of course, you can see in men, we have a Q value different for white and Black. This is true. But you see, and when you go into the details of all the literature, this is something that you can see that the difference between Black and white women is not so important. And actually, this is exactly the same value. So this is not a question on race, even in the societal meaning. Probably there is something else to explain the difference between Black and white, because once again, in women, this is exactly the same. So we use the Q concept with the population specific, but of course, because all the debate about race, we didn't want to be accused of racism. And so we also developed the concept of the race-free Q value. And the race-free Q value is actually very simple. It's just the mean of the two Q values. And you have a totally race-free Q values. So we try to validate the EKFC in the cohort I have just described. And you see here in blue and in green, the race-free and the population-specific result in terms of bias for the EKFC and in terms of accuracy within 30%. And you see that the results are globally similar, even still a bit better for EKFC in the young population, which is, I think, remarkable, because once again, we have tested the EKFC in a real external validation cohort, whereas the cohort I show you, most of them have been used to develop the CKD-EPI equation, and we all know that an equation is always performing better in the cohort used for the validation, of course. But this is not the case with EKFC. We have very, very good results, even in US cohort. And this is exactly the same picture in some subgroups according to gender and to race. And also, one point I would like to underline with you is this result in China. We have data, a large amount of data about serum creatinine in healthy people, and you see that the Q value in China, and probably also maybe in other Asian people, if I well understood, the Asian population is very important in your country. The impact of the the impact of the Q value on the Asian population is also very important, because you see that the Q value are very different. And I must say that in the CKD-EPI consortium, they focus on Black and non-Black. They totally ignore the Asian population also in US. Maybe it could be also of importance to consider this patient. So a few summarize about the EKFC creatine-based equation. The main advantage, I think, of EKFC is its flexibility. You can use the Q factor that can be adapted to every population. You can also use a mixed racial Q value, and you can also use a totally race-free Q value. Q value can be obtained for large or very specific database. Most of the time for Europe and from US, you use database from laboratories with thousands of results of serum creatinine. But in specific population, like in Africa or Black European, we didn't have access to so large database of creatinine. So in Black European, for example, we define the Q value calculating the median serum creatinine in a specific LC population of living kidney donors. So there are different ways to consider and to calculate the Q value. And most important, I think, is the fact that Q value can be obtained actually in every hospital. You can easily calculate your Q local value, and this is reflecting actually the ecology of your population in your hospital. So you will say, this is true, this is a limitation. Q is a population-based concept. This is true, but in fact, GFR is a population-based concept. And we can say, okay, if one patient moves from one hospital to another hospital, if we have different Q value, it will impact the result of GFR. This is true, but we should not emphasize this impact. Of course, there is an impact, but you see here that for a male person with a Q value of 0.9, if the the change in Q value is 1.01, it will be corresponding to an GFR of 0.75. So if we move, for example, from 0.9 to 0.97 for Q value, the EKFC will move from 60 to 55. So I don't tell you that there is no impact, but the impact is relatively limited. So now Cystatin C. The Cystatin C is a relatively new biomarker, and you know the main advantage of the Cystatin C is the fact that the concentration of Cystatin C seems to be relatively independent on muscular mass, at least more than for serum creatinine. And this has been published by the CKD-EPI consortium in 2012. Once again, large cohort and large data set. And you can see here one advantage of the Cystatin C CKD-EPI equation is the fact that you don't see the race variable in the Cystatin C equation. To summarize a very busy slide, it's very simple. What about the performance of Cystatin C-based equation? Once again, it's very simple to keep it to keep that in mind. The first fact is that creatinine-based equation and Cystatin C-based equation have globally, in the global population, the same performance. So Cystatin C-based equation is not better than creatinine-based equation. The better equation, the best equation, is the equation combining creatinine and Cystatin C. When you combine two biomarkers in one equation, then you gain in performance. You have a gain in performance in terms of bias and in terms of accuracy. So, of course, with the EKFC consortium, we try also to develop the EKFC Cystatin C-based equation, and we were lucky to have this publication in the New England last year. So the first step, once again, like for creatinine, we think about the physiology, I would say. So the first thing is to see the association of Cystatin C with age. And you see that this is a bit different compared to serum creatinine because you don't see very well, but there is an increase in serum Cystatin C with aging. And we had data from Sweden, and Sweden, for the researcher in eGFR and measured GFR, is an ideal country because Cystatin C and measured GFR are routine. In clinical care, all patients at the emergency, in cardiovascular surgery, all patients, they have Cystatin C measured. So we have a large set of Cystatin C. So as cystatin C is increasing, normal or median normal serum cystatin C is increasing with age, we had to include age in the Q value, contrary to cystatin C, also for adults, I mean. And you see that for sex, there is a slight difference between males and females regarding the cystatin C value, but the difference is much less important than for creatinine. And so we had the idea to say, okay, let's try to use one unique result of cystatin C for the Q value. And if the Q value is sex independent, it makes the EKFC equation, of course, totally sex independent. I will show you that it works. So the Q value is the same for males and females. So what about race? So we use the same data I have described previously from Paris with GFR measure with the same method, creatinine statin C measure with the same method, and we had black and white European people. And what we did, you see here the sample size, but we did a match analysis. We matched the analysis for sex, for BMI, for measure GFR, and for age. The matching was correct, and you see the sample size, and you see that the age in the match group were the same, of course. And you see that cystatin C was not different between black and white men and white women and black women, which is, of course, this is expected not the same for serum creatinine. So once again, these data are also confirming that cystatin C is independent on race. And the first step was, of course, to validate the new equation. And this is very important that you understand that the EKFC cystatin C-based equation is actually the same equation as the creatinine-based equation. The exponent applied to age, for example, is exactly the same. The exponent applied to the ratio between Q and the biomarkers are exactly the same. Only the Q value is changing, of course. So we have validated this equation also in a large database. And I will show you the result in the largest database, which is in European white people. And you see that EKFC, the bias and the P30 is much better than the CKD-EPI equation, the race-free CKD-EPI equation. Also, the EKFC cystatin C-based equation is better than the CKD-EPI cystatin C-based equation, especially in terms of P30. But once again, when you compare creatinine with cystatin C-based equation with one single biomarker, there is no difference. I mean, CKD-EPI, cystatin C, also in our hands are not better than CKD-EPI creatinine, and EKFC cystatin C is not really better than EKFC creatinine. And this is the same in the small cohort of white US people. You see here the result of the combined equation. So you can use a combined EKFC equation, which is actually very simple. This is just the mean of creatinine and cystatin C EKFC equation. You see that the combined EKFC equation is better than the CKD-EPI combined equation, with an accuracy within 30%, reaching 90%, which is very good. And also the EKFC combining equation is better than EKFC using single biomarker. So using an equation with two biomarkers is better than using an equation with one single biomarker. We have very recently, I had no time to go into the details, but we have very recently extended the cystatin C-based EKFC equation with children. So cystatin C allows an eGFR without race nor sex, at least with the EKFC. EKFC is mathematically the same as EKFC creatinine, EKFC cystatin C. Only the Q is changing. We have a continuum between children and adults for EKFC creatinine and also for EKFC cystatin C. EKFC-based equations based on cystatin C, are not better than equation based on creatinine. This is the same story for CKD-EPI and EKFC. EKFC equation are slightly better than corresponding CKD-EPI equation. So I think that there are arguments to say that this is a good alternative to CKD-EPI in Europe and Africa, and maybe also in US. Combined equations are better than equation using single biomarkers, and the gain in accuracy within 30% is between 5 and 10%. What we still need to improve, even if a lot of improvement have been done in the recent years, is the standardization of the assay for cystatin C. There are still not totally standardized. But once again, a lot of improvement in the last year. And of course, the most important is the fact that cystatin C still and remain more costly than serum creatinine, which is very cheap actually. An important question for the future and for future research is how to manage discrepant result. If we use cystatin C and creatinine, of course, we will have sometimes, it's not so rare, it's relatively frequent, discrepant result. How do we have to manage these discrepant results? So the place of EKC cystatin C in the next KDIGO, of course, we were very curious to see that. And I just show you here the side where you can have a calculator for EKC. So the new KDIGO, a few words about the new KDIGO. Of course, I have no time to go into the details, but basically what you can read is that the place of cystatin C is increasing is the new recommendation. And you see this diagram. So the initial test, of course, remain GFR creatinine. But if we consider there are source of error in creatinine, or if more accurate assessment is necessary to measure cystatin C, and then reconsider the errors, the accuracy needed to maybe measure GFR. I must say that I'm not totally, I do not totally agree with this diagram, and I will show you why later. Also, regarding the selection of GFR estimating equation, I must admit that we were very happy to see that the KDIGO accept the EKFC equation as a valid GFR estimating equation. This slide is also very, very important. And this is, I show this slide in every presentation I do, because this is crucial to keep in mind that serum creatinine is the limitation of eGFR equation. I mean, if serum creatinine is presumed to be bad in a given patient because of abnormal muscular mass, you see some examples here, there is absolutely no reason to think that estimating equation would do better. This is very important. We must keep our clinical feeling, and equations are not magic. If there is an error with serum creatinine, actually you apply an exponent to serum creatinine. So you apply an exponent to the error. So the error will be still higher with equation. Always equation remain estimation. They are good at the population level, good tool for epidemiology, but they all lack of precision at the individual level. I'll just show you this illustration, very illustrative, I think. You have the serum creatinine, you have the eGFR, and you have just here the difference between applying with the CKD-EPI 2009 the race coefficient or not applying the race coefficient. And you see that there is a difference between the two results, of course. But the difference is relatively negligible or small comparing to the precision of the equation. You see the precision, the confidence intervals here is quite larger than the difference between the two equations. And also you see sometimes in the literature, or sometimes some labs give an estimating result with 2 decimals, which give a feeling of precision, which is totally misleading. We should give the confidence intervals, and you will agree with me that the feeling of precision is much less impressive. So in some situation, I don't tell you that we have to do that in every patient, no. But in some patient or in some clinical situation, we have to measure GFR. And we have different ways to measure GFR. And I think that for the moment, worldwide, the most used is probably aerosol plasma clearance. And I show you some publication, it's open access in Clinical Kidney Journal, about why and how to measure GFR with aerosol. I just can say that it's not so cumbersome. Of course, it's more difficult than measuring serum creatinine, but it's not so cumbersome, and especially it's not so costly. And I know that Christine Wright is working very hard on a new publication for the standardization of measured GFR by aerosol plasma clearance, and I'm sure that she will present the result very soon to you. So this is also recognized by the KDIGO actually. They clearly state that where more accurate assessment of GFR will impact treatment decision, measure GFR using plasma RNA clearance of exogenous filtration markers. So this is clearly stated in the KDIGO that we have to measure GFR sometimes. So just, this is my last slide, just to tell you that I was a bit in disagreement with the diagram of the KDIGO, because I think that the most important and the first question should be, when I have estimated GFR with creatinine-based equation, is a high degree of precision needed for this patient and or for the clinical situation? If the answer to this question is yes, I don't think that we have to measure cystatin C, because the level of precision for cystatin C is not better actually. But I think that we have to directly measure GFR with a reference method. If the answer to this question is no, then we can ask the question of the KDIGO, is there a risk for serum creatinine to be inaccurate? If no, but we can only use creatinine. If yes, we can use cystatin C. And then the question after will be, is cystatin C discrepant with creatinine? If there is no discrepancy, there are good reasons to use both equation in the same, both biomarker in the same equation. If there is a discrepancy, I think that we can also ask again the question of the precision and maybe measure GFR. Otherwise, when you have discrepant results between creatinine and cystatin C, I must say that we still don't know exactly what to do. Probably to use the combined equation, but it's not so sure that we need for further research on the discrepancy between creatinine and cystatin C. Why? For us, this is important to measure GFR, and not to measure GFR, but to ask if we have to measure GFR is once again the precision. I show you here just the performance of the best equation. Of course, the best equation is the EKFC combined equation, and you see that the P30 is 19%. But if you need precision, a P30 is absolutely not enough, and you can go for a P10%, an accuracy within 10%. For example, for living kidney donors estimation, you can say, okay, I need a high degree of precision. And when you consider the accuracy 10%, yet you see that the performance is 50%. So you can flip the coin. This is the same story. So once again, I think this is very important. And I thank you for your attention.
Thank you. That was a wonderful overview of the GFR equations. It's really gave a lot of food for thought about what we are doing, because we use mostly CKD-EPI here. Manish has already got a question. Go ahead, Manish.
Thank you for that. Nice to meet you, and thank you also. I know you've reviewed some of my work in the past, and thanks for the kind words. I'm on the exercise bike, so don't mind me. Two questions. One is, what has the acceptance been for your new equation? And I'll tell you why, because I get the sense that if I submit any paper to any US-based journal, they will immediately come back and say use CKD-EPI, despite the data that you've shown. So I wonder if it'll turn out to be a cross-Atlantic kind of schism, in which sense I'll say, of course, I would say Canada or me would side with the Europeans. The second question is, and sorry for these being a little big, is your comparison is to the true GFR, like the natural phenomenon. There's been a movement towards risk-based GFR use with kidney failure risk equation. And I was just wondering if you have any risk-based data for the new equation and how it associates with risk. Thank you.
Oh, two very interesting questions. So for the first one, of course, I can tell you that we share the same feeling. Of course, what can I say? I just can say a few things. First, I don't think that the KDIGO are grave in stone. I think that the KDIGO are to give us some ways to do, but this is not the end of the research. We can still try to do better. And if you show and we prove that we do better, I don't know why we should change, why we should not change. Okay, but okay, I understand that it's not always easy to change, and I have experience in my submission, the same bad experience as you, of course. But what can I do? What can I do? I think I just can say that in all medicine we did the job. We tried to develop an equation. We publish it in relatively good journal, Annals of Internal Medicine, New England. What can I do more? I try to give conference to convince the guys, but okay. I know that the big challenge for the EKFC would be the implementation of the equation. And between you and me, I'm not totally naive. I don't think that the EKFC will be used in US particularly, because there is also a lobby, etc. Okay, but at least I hope this equation will be used in Europe, and maybe why not in Canada. But I know that we have to convince, and that we have to, as always in SOS, when we have a novelty, we have to convince, and this is normal, and this is the whole job. The second question is also very, very important. You talk about the prognostic. I have an answer in two parts. The first part is a bit provocative, but okay, once again, we are between friends as we can. My first answer would be to say, okay, I do not use estimating GFR to predict the risk of the patient. Okay, I use estimating GFR to estimate GFR. Okay, for drug dosage adaptation, to classify the patient, etc., but not to predict the risk. And you know why? This is very important, because I think that this is a point that is not very discussed, of course, by the CKD-EPI consortium. But when we go into the literature and you read some data with different equations to see which equation is predicting the best the risk of mortality, for example, you know which equation is predicting the best mortality? This is Cockcroft equation. This is the Cockcroft equation, which is this equation is a very good equation to predict the risk. Very good. And why? Why? Because I think my interpretation is the way age is considered in the equation. And I would say the mathematical power that you give to age in an equation, I think it's very important for the prediction of mortality, you know? And the fact is that the mathematical power of age in Cockcroft is very important compared to CKD-EPI and EKFC. This is my first answer. My second answer is to say, okay, we don't have data on outcome in the EKFC consortium for the moment, so I can tell you, but at least there is one publication in Clinical Kidney Journal with data from the SPRINT study, and they try to compare EKFC with CKD-EPI in terms of prediction, and globally this is the same story. So we do not do better, but we have the same performance, I would say, to predict the risk.
I'll add one last thing. If you want to look at it, in Ontario, we have creatinine values at least 12, 13 million now. So it could be looked at. If you're interested in, please feel free to send me an email.
Yeah, for sure. Yeah, for sure.
Thanks for that. Ayub, unmute yourself, please.
Thank you, Pierre, for an excellent talk. Really enjoyed it. I have two questions. First, I wanted to let the audience know that we can measure cystatin C at TOH. You can just order it in EPIC. So my question is that even in the best of hands, the accuracy in 30% is about 80 to 85%. Do we know what are the factors that those 15% of the patients, how can we distinguish them so that we know that these are not going to work? It's not just the muscle, because cystatin C has the same limitation. Yeah. And my second question, okay, go ahead.
Sorry, I would not say that this is the same limitation. The cystatin C has other limitation, I would say, because, you know, if cystatin C was better, the performance of cystatin C-based equation would be better. This is not the case. In the global population, cystatin C has the same performance as creatinine. That means, in my opinion, that the determinants, there are also non-GFR determinants for cystatin C. Because if there were no cystatin C if there was no non-GFR determinants, the performance of cystatin C would be better. It's purely logical. So now we have, and this is very important, because this is what the KDIGO say. If you think that creatinine is not good, you have to measure cystatin C. It's easy to say, but it's not so. In practice, it's not so easy actually. Okay, you can imagine that you have a patient with anorexia nervosa, for example, or an obese patient. You can logically say, okay, in this patient, it's not accurate. It won't be accurate, but it's not so simple. I see. It's not so simple, and this is, I think, but this is for the future. Maybe there is a place for artificial intelligence here to know which parameter altogether to know, to help us, maybe not to estimate GFR, but to know if we have to estimate GFR, for example, with creatinine, with cystatin C, with both, or if we have really to measure GFR.
And my second question related to medication dosing. As you know, all the equations that you mentioned, except Cockcroft-Gault, is in mLs per minute per 1.73 meters squared. Only Cockcroft-Gault is mLs per minute. So would you comment on that? Because converting the mLs per minute per 1.73 meters squared really needs the height.
The first thing is why the MDRD equation, the CKD-EPI equation, and the EKFC equation are using the BSR index MGFR result. I think that the reason why is the fact that when you use the BSR index GFR result, in the calculation, in the regression analysis, weight is disappearing. Okay? Because weight is already in the BSR. And this is very important because the laboratory do not know the weight. And so we can give an automatic result when you prescribe a serum creatinine. This is the reason why. No, for drug dosage adaptation, this is true that we have to de-index by BSA. And this is not Pierre Delanaye who tell you that. This is the FDA, this is the EMA, and this is the KDIGO say that. So it's probably true. But I agree with that. I think that we have to adapt the drug dosage of the GFR of the patient, not of the GFR that the patient would have if BSA was 1.73. So I think I do agree that we have to de-index. But no, strictly speaking, from a mathematical point of view, de-indexing is not always correct, actually, mathematically speaking, because we de-index for patients who are not included in the cohort used for the validation of the equation. So, but okay, we have no choice. And I think that de-indexing the equation, even if it's not sensu stricto totally correct, is better than non-indexing. But we must also keep in mind for all clinicians here that the question of indexation is only relevant for very high or very low BMI. So not the majority of our patients. This is relevant, I mean, only for obese and very anorexia patient, etc.
Yeah, so you would agree that what is being reported to us in those extremes of body surface area, we should not be using the reported GFR?
I'm not sure I have well understood what you mean.
So what I wanted to say is for patients with extremes of body surface area, or when we are using cutoffs, like, you know, we won't give this medication if GFR is less than 30, we should not be using the index GFR, the reported one.
Oh yeah, it's very challenging actually. This is exactly the same story in still worse situation in ICU. You know, how can we do in ICU patient? You know, with edema, etc. Well, you don't know the weight of the patient. What is the weight of the patient hospitalized in ICU department? I don't know. So it's very challenging. All I can say is if you need to give a potential nephrotoxic drug with a narrow window, therapeutic window, you have no choice. You have to measure GFR in this patient, for sure. This is a clear indication for me to measure GFR. I know it's not always easy, but it's a clear indication. I think that every big center in nephrology should have a technique to measure GFR. It's not so complex. This is not true. This is not so complex. And second, and this is my message to pharmacists, etc., and to clinicians, when it's possible and when you have this type of patient, measure the drug, monitor the drug every time, as frequently as you can. For example, in ICU, measure vancomycin, measure gentamicin if you can, measure, monitor.
Thank you.
Yeah, that sounds like a good idea. I'm sure. Christine, I will give the last question to Christine.
Great, thanks, Swapnil and Pierre. That was an excellent talk. I just have a quick practical question about implementation in Europe. What sort of steps are you taking, and are different countries considering adapting their own Q values, or is it going to be a pan-European value? And your thoughts on this?
You mean for the implantation of the EKFC equation?
Yeah.
So, for sure, of course, we are working with we are now working and discussing with the European Renal Association. For us, of course, as European, it is the most probably the first step, I would say. And then we are talking also to national nephrological societies of nephrology to try to implement. And I think also that we have to still convinced by scientific evidence. So we are still working on EKFC for the moment. We are working very hard on the discrepancies between creatinine Cystatin C-based equation, and I think that it will be a bit indirect, I would say, but we will have also good arguments for EKFC regarding the discrepancy between creatinine and Cystatin C. But it's in the pipeline. Voilà.
Thank you. So with that, the EKFC CKD-EPI reminds me of the Betamax versus VHS wars of the 20th century. The better product is used in the minority still. But with that, thank you, Dr. Delanaye, for that wonderful discussion
Thank you very much.
of measured GFR and EKFC and Cystatin C. Thanks again for presenting.
Thank you for the invitation. Thank you very much. And sorry for the French accent, but
no, we are used to the French accent. That was not a barrier at all.
Bye-bye.